Good afternoon, everybody. Thank you for the organizing committee for inviting me. It's an honor to be here with you and with my colleagues from abroad and from UM. I'm an interventional radiologist, and I just want to give you a brief overview of what are the types of procedures that we do for cancer patients, and more specifically for therapies intended to treat metastatic liver disease. So again, we're just going to review a little bit about what we do. What is an interventional radiologist? Well, basically we're the plumbers, in all this story. We use imaging guidance to guide different instruments to the organ where the malignant disease is. I would recommend you to visit sirweb.org is the website for our society, and there's a section for patients where you can actually read about all the different type of procedures that we perform, including the cancer-directed therapies. So where are the more commonly performed IR procedures in cancer patients? Well, we're involved in the care of cancer patients from the beginning, basically from image-guided biopsies using ultrasound guidance. As you can see, a needle is being advanced into a liver mass guided by ultrasound. Sometimes we utilize CT guidance to achieve the same, depending on the type of lesion that we're trying to biopsy. We're also involved in getting central venous access so that all these systemic chemotherapy agents and immunotherapy agents can be administered safely and effectively to the patient. Basically, that is easily performed by just advancing a needle into the jugular vein, and usually a catheter is tunneled from a chest incision all the way to the venotomy site, and then a sheath is placed through the wire that we got access into the jugular vein, and then the catheter inserted through that sheath. These are just two different types of these tunnel catheters that are meant for long-term infusion of drugs. Also, obviously, as part of the central venous access, we do place ports, which are basically central catheters, but instead of having an external component, they have a deposit that it's implanted subcutaneously through a small incision. And then here you have an x-ray with the final, what it looks on x-ray. You have the port with the catheter extending above the collarbone and then going into the jugular vein and sitting right on top of the heart. Now, what is interventional oncology? Interventional oncology it's a branch of interventional radiology. Some of us that are interested in the therapy of cancer patients do image-guided minimally invasive therapies to treat primary and metastatic disease of multiple organs, including the liver. And among those therapies, we have ablation techniques and embolization techniques. Usually, the decision to go ahead with these treatments is made in a multidisciplinary approach where we are actually as interventional oncologists, part of the team, together with the radiation, medical, and surgical oncologists. Once the patient is deemed a candidate for potentially could benefit from one of these therapies, we usually see the patients in clinic and explain the procedure, evaluate, make sure the patients are candidates for these therapies. The ablation techniques, which are basically the techniques we use a direct needle to burn the tumor, generally require general anesthesia, so often we send the patients to make sure that they're able to undergo general anesthesia. And then usually the patients are observed in the hospital after the procedure for 23 hours, most of them going home right after that. And we usually follow the patients in clinic. So let's talk a little bit about ablation techniques. Basically, ablation techniques is using ultrasound or CT guidance to get special probes to the tumor within the liver, and then applying energy that ultimately is going to heat the tissues or to kill the tumor. This usually is indicated in patients that are non-surgical candidates and have oligometastatic disease. What that means is lesions are small in number and in size. So basically, we can consider these techniques for patients that usually have disease in one of the two lobes of the liver, and they're usually a small number of them. Some patients that, the disease is limited to the liver. Some patients may be considered for these techniques, even if they have metastatic disease elsewhere beyond the liver, as long as the extrahepatic disease is deemed curable. So between the different ablation techniques, very quickly, we have three types that are mainly used for the liver. Thermal ablation basically are probes that deliver energy and generate heat and kill the tumor. And then we have this newer technique, which is called irreversible electroporation, which is not mainly dependent on heat, but a different mechanism that I will explain. Thermal ablation is the original technique, and basically what it is administering alternating currents between the probe that we place in the tumor and a pad that usually gets placed on the thigh of the patient. The alternating current between the probe and the thigh pad creates agitation, friction, tissue heating, and finally coagulative necrosis, basically tissue death of the tumor around the probe when the temperatures reach between 50 and 100 degrees C. Microwave is a newer form of thermal ablation, and basically instead of delivering alternating currents, what you do is you give frequency, you put an antenna into the tumor that gives frequencies between 915 megahertz and 2.45 gigahertz. This in turn makes the water molecules within the cell start oscillating, and again friction is generated, there's tissue heating, and again finally coagulative necrosis, which is tissue death. The potential benefits of this newer modality is that you can achieve larger ablation zones. This is still question mark because there's still hasn't been fully proven, but that's the idea behind this newer technique. You can treat larger lesions. Now, the thermal ablation techniques have one caveat that is important to understand, is the heat sink effect. And that basically is when you have a tumor, you have the probe generating heat. You can see that the heat in this side of the tumor is higher than in this side, because here you have a big vessel that it acts like a radiator in a car, basically taking the heat away, and that's the heat sink effect. So when we treat liver lesions that are near big blood vessels like the portal or hepatic veins, we should consider other treatments, because oftenly what's going to happen is we're going to have incomplete treatment of the lesion near the vessel. So that's where irreversible electroporation comes into play. My boss, Dr. Narayanan, is a world leader in this technology. And basically what it is again putting probes into the lesion, but instead of generating heat, what you do, the high voltage, low energy electrical pulses permanently open pores on the cell of the membranes and basically make the cell contents leak out and the cell dies. So again, this is very useful because it's not thermal, so therefore you don't have the heat sink effect, but also you can treat lesions that are close to, for example, you may have a lesion in the lower part of the liver that is close to the colon. You won't burn the colon, you won't cause damages of vital structures, because basically the scaffolding around the cells, basically made of collagen, is not affected by the technique, as opposed to like heat. When you heat something, everything dies, including the cells and the collagen networks. So this technique actually spares vital structures like vessels and biliary ducts and other organs. So it's very, very interesting. So here we have a case of a single metastatic lesion to the left hepatic lobe. It's a little hard to see. It's a little bit, you can see a little bit of enhancement there. And then here you see the lesion under ultrasound, and here you can see the tissue probe going into the lesion, and then it gives you this cloud appearance once you start heating up the tissues. Here you have a confirmation of the needle placement, of the probe placement within the liver under CT. So often we use both modalities at the same time. And here's the follow-up. You can see how this lesion now turned to be smaller. You have basically devascularization of that area. You don't see any enhancement. So that's a good result. So most of the literature for ablation techniques is in the treatment of colorectal metastases of the liver. The complete responses are very good, and the 5-year survivals are very good too. For uveal melanoma, recently there's a paper from 2016 that they treated 20 patients with 75 liver lesions. Their success rate was similar to the colorectal data, about 89% for the primary success, which means after the first ablation, almost 90% of the time the tumor didn't recur. For those that recur, they treated a second time and they obtained a complete success rate of about 93%. And they observed overall survival about almost 20 months. Another paper compared patients treated with just surgical resection and surgical resection plus some radiofrequency ablation in order to try to do less surgical resection to preserve more liver function. And interestingly, they found that the overall survival was very similar for the both groups. So this is, I think, good news because it shows that often you can spare liver tissue by maybe combining both surgical and radiofrequency ablation techniques. Okay, so now finally for the last part, we're going to talk about the embolization techniques. Mainly there's two ones that I'm going to talk to you about, and that's Trans-Arterial Chemoembolization and yttrium-90 Radioembolization. These are indicated for non-surgical patients with diffuse metastatic disease. As opposed to ablation techniques, these are for patients that have more than 5, and usually bilateral, both lobes of the liver are involved. So these come down the road. Or also they can be used for singular lesion, but when they're very large, and ablation techniques won't be able to cover the entire lesion. So again, they're more palliative therapy for selected patients with unresectable tumors. Most of the data is for primary liver cancers, but they have been used for metastatic liver disease, particularly colorectal cancer, mets, and breast, but there are papers, there are studies from Dr. Sato's group using these techniques for melanoma, uveal melanoma metastases of the liver. So who are the candidates for these procedures? Those with metastatic disease confined to the liver, they have to have adequate liver function. As you will see, some of the treatment involves blocking the arterial flow to the liver. So that's why this is very important. And usually we look at that by looking at your bilirubin level. Okay, and it's very important that the patient has a good functional status. So here, very briefly, basically these two procedures involve getting a catheter from the groin artery, the femoral artery, into the liver artery. Basically, you get a sheath access into the artery, then under fluoroscopy, which is live X-ray, you manipulate the catheter all the way to the celiac artery. The celiac artery is the artery that provides, divides into splenic, gastric, and hepatic artery, and basically you just get drive a catheter all the way up to that point. Once you're in there, then you have the ability to inject the therapeutic agent. In the case of trans-arterial chemoembolization, basically you're giving a cytotoxic drug that then is usually followed by microspheres that block the flow of blood into the tumors. In the case of radioembolization, what you're injecting are spheres that actually have yttrium-90, which is a radionuclide, an internal source of radiation. And the beauty of that is that, as you'll see in a few seconds, you're basically focusing the treatment to the tumor and sparing the liver. So for TACE, basically, like we just said, we drive a catheter to the hepatic artery and deliver cytotoxic drugs, resulting in a higher concentration of the drug into the tumor and less into the rest of your body, therefore hopefully decreasing the amounts of adverse effects and improving the efficacy within the tumor. And then again, like I said, in TACE, the microspheres they're bland. They basically don't have anything inside and are just meant to stop the flow of blood to the tumor, that basically making the drug decrease the washout of the drug from the tumor and increase the time the drug spends within the tumor, killing it. These are, I'm not gonna bore you with this, but these are all the different types of drugs that we use when we do TACE. That's the problem. I think there are no comparative studies showing which one is of more benefit for metastatic disease in general, and I think obviously more comparative studies are going to be needed. Here's an example of a result after a TACE. You see the 2 lesions there in the right hepatic lobe, and then in follow-up you see the shrinkage, actually quite significant of the lesions. So radioembolization, in some patients, the application of external radiation may not be possible because the liver tolerates up to 30 to 50 grays of radiation. Anything higher than that may put you in liver failure. And usually the tumors require 90 to 100 grays to achieve cell death. These limitations can be overcome by delivering the radiation directly to the tumor, and that's by delivering microspheres with the Y90 directly to the vessels that feed the tumor via the catheter that we inserted into the artery. And you can achieve up to doses to 150 grays. The bulk of the liver is spared because once the radiation is within the tumor, it only travels up to 1.1 centimeter, in average 2.5 millimeters. So therefore, it kind of remains within the tumor. One thing important to understand for radioembolization, it actually takes 2 sessions. The first session, you actually come just to get an angiogram of the liver, where the main intent is to actually find the gastroduodenal artery and the right gastric artery, and those are the 2 main arteries that irrigate the stomach and the proximal small bowel, because it's very important to. The reason we block those arteries because we don't want the radioembolic beads to go there, because then can get gastric ulcers and duodenal ulcers. So we just take them out, and actually those organs survive just as well through collateral systems. So you don't really need those arteries, and we take them out just for the safety and avoid these complications. The other important thing that we do in this first session is that we're looking for shunting of blood from the liver to the lungs. And once we finish embolizing, we inject macroaggregated albumin with technetium-99, which is a non-therapeutic radionuclide. And basically, in this case, we can see how the activity is all in the liver and it's not depositing in the lungs, which is very important, because otherwise the patient will not be able to undergo the therapy, because then you are going to get damage of your lungs. And then here's a case of, as you can see, much more diffuse metastatic disease, multiple lesions everywhere. And then these 2 follow-ups, you can see how the lesions have decreased in size, some of them even disappeared. So one thing in common with these 2 embolic is the post-embolization syndrome. Basically is low-grade fever, abdominal pain, nausea, and vomiting. It usually subsides within 48 hours. It's reported on a wide range. It's more frequently with TACE than 190. And liver failure is very rare, particularly because we obviously do these in the appropriate setting when there's no liver failure. I'm just going to quickly go through some of the data as it pertains to melanoma. TACE has been done with this agent specifically for melanoma, BCNU. Dr. Patel in 2015 had a phase 2 trial, and they found that a 20% response rate with a median survival of 7.4 months, which doesn't, it's not much more than patients with liver melanoma metastases that don't undergo treatment, which is between 2 and 7 months. However, they find that if the liver involvement was less than 20%, up to 33% rate of response with an overall survival of 19. So I think what this suggests is that early detection of liver metastasis is key, potentially so that patients can undergo surgery or ablation techniques, and if not, this as a second alternative. Here's another study from Dr. Sato's group where BCNU was utilized for bulky uveal melanoma, basically metastasis involved more than 50%, and again, the overall survival was about 7.1. How about radioembolization? So for radioembolization, Dr. Sato's group again studied 32 patients, and they found that with the 190, they obtained an overall survival of 10 months. Now, again, notice how for patients that had a relatively small amount of liver disease compared to those with more than 25% involvement, there's a difference in the overall survival. So again, early detection and treatment, I think, is going to be key as we look more into these therapies. And just for completeness sakes, as other have mentioned before, there are other alternatives for example, intra-arterial chemotherapy is like TACE, but without the spheres that block the flow of blood. So basically, you just deliver the cytotoxic drug. This usually is reserved for patients that have poor liver function. Okay, so we can do that, but we don't block the arterial flow so that we don't worsen the liver function. So that it has been looked into also. And then immunoembolization, which is basically delivering the immunotherapy agents directly into the artery. It's also something we're looking forward to seeing more data on. In conclusion, interventional oncology plays an important role in the treatment of non-surgical patients with metastatic disease of the liver. Research is needed to evaluate more in depth the role of biotherapies for uveal melanoma patients. I appreciate your time, and I know it's been a long day, so.